Just doing general effects of anemia, but we're going to move on to some general what anemia is. We're going to move on to the effects of anemia and then causes of anemia in detail, because there's a bunch of different ways people can develop anemia. So anemia can range from very, very mild to very, very severe. Mild anemia, you may not have any symptoms whatsoever, usually no clinical symptoms. If somebody's elderly with other issues, they may have symptoms, but otherwise you could have mild anemia and be completely unaware of it. As it becomes more serious, an obvious thing is going to be fatigue, just not having the oxygen carrying capacity, not being able to develop the ATP. It's going to have a very literal effect on your energy level, and fatigue, weakness, loss of stamina, possibly resulting in tachycardia. And again, we'll talk about the heart later, and heart pathology is coming up a little bit later than all of this. But we'll talk about how some of that how weird things can lead to increased heart rate. It's not always what you expect. As it gets more severe, we do worry about things like orthostatic hypotension, standing up and feeling head rush, vasoconstriction, pallor, cramping in muscles, headaches. One sign can be tinnitus, roaring in the ears can indicate anemia in some cases. All right, so a lot of things are contributing to your development and maintenance of your red blood cells. So there is aplastic anemia, in which your red blood cells simply are not being formed, generally because you don't have the stem cells for them. There's also renal failure. Remember that your kidneys are the ones that are releasing erythropoietin. Erythropoietin is the hormone that tells your red blood cells or tells your bone marrow to produce red bone marrow to produce red blood cells. Okay, words. I have words today, I promise. I can do this. So in renal failure, you'll have the disease of renal failure, but you also may develop anemia as a result of that. The vitamin B12 is absolutely necessary for synthesis of DNA, cell division within the red bone marrow to produce more red blood cells. Without vitamin B12, then synthesis will be decreased. Iron deficiency anemia, hemoglobin, the heme part of hemoglobin has an iron molecule bound to it. That is actually what enables you to bind to the oxygen. And hemoglobin is actually a structural part of the red blood cell. So without iron, you can't make hemoglobin. Without hemoglobin, you can't make red blood cells. So very directly iron deficiency anemia. The lack of the heme part, yeah. And then for the B12 deficiency, for that one, would that be like extreme fatigue because B12 gives better? Exactly, yeah. I mean, just our general effects of anemia, including fatigue, yes, that would be reflected. So I'll tell you guys a funny little story. Funny, not funny, haha. It was when I was teaching at an acupuncture college, one of my first teaching gigs, along with my teaching gig at Metro at the same time. Teaching acupuncture students, most of them were vegetarians, and one thing that acupuncturists are trained to do and allowed to do as part of their scope of practice is give very specific injections, such as a B12 injection. They are legally allowed to do that. So they had a training day where they learned to give B12 injections, and suddenly all of my students had energy. Yeah, it was great. So all of my vegetarian students all of a sudden had a great energy. And it's not to say that you shouldn't be a vegetarian, it's just to say if you're going to limit your diet in any way, you should be very conscientious of what nutrients you are or are not getting. You may need to supplement. You may need to be very specific about what you eat. You may need to find vegetable sources with high bioavailable B12. Whereas if you're a meat eater, you're getting B12 very easily from your diet. You don't have to think about it as much. Same with iron deficiency. If you have a cast iron skillet, you're actually pretty good. Get a cast iron skillet. Cook your food on it. It'll give you iron. I believe we already talked about thalassemia a little bit. Increased red blood cell destruction resulting in decreased red blood cell survival rates. And again, when we're destroying red blood cells, usually that means there's something wrong with the red blood cell. It's not that your spleen just decides to destroy everything one day. It's that your spleen is seeing defective red blood cells and is doing its job to the best of its ability, right? So having some mutant genes that change the globin chain, for example, alpha thalassemia, beta thalassemia are going to be examples of genetic mutations. So most clinically severe form of thalassemia is thalassemia major. I believe so. Yes, I believe we did talk about that. Another form of anemia is sickle cell anemia. This is another genetic condition. Sickle cell anemia means the gene that codes for adult hemoglobin is deficient. And again, that hemoglobin is part of the structure of the red blood cell. So the result is very fragile red blood cells. So there may be periods where those red blood cells are okay, but some event may trigger them to collapse and take on this sickle shape. At which point your spleen and liver are going to work very, very hard to try to clear them out, and you will be anemic during that phase. That sickle shape is also going to increase clotting. Any place where a blood vessel bifurcates, which means splits into two, it's going to get stuck on that bifurcation and cause blood clotting, and especially very small blood vessels. It's going to be especially painful in joints or in near joint spaces. So this will be a very painful episode as well. Sickle cell anemia, again, these anemias that are based on destruction of red blood cells by the spleen, a lot of them are going to cause splenomegaly. Some of them may actually eventually destroy the spleen. And somebody with who's been dealing with sickle cell anemia for a long time may be considered asplenic, is the term. They no longer have a spleen, or they no longer have a functional spleen. And that's also considered something that makes you immunocompromised to not have a spleen, because that spleen is also a maturation cell or maturation site for certain white blood cells. Okay, then we go the other direction, polycythemia, meaning too many red blood cells. There can be primary from a myeloproliferative disease, overproduction of blood or bone marrow. Secondary related to chronic hypoxia. So here's a fun fact. We're all a little polycythemic in this room because we're all in Denver, Colorado, hanging out at 5280 feet. We're all at a low oxygen level in the environment, so we're all increasing our EPO, and we all have slightly higher red blood cell count than people who live at sea level. But that's physiological for this area, and it's normal, and we do have compensatory mechanisms that help us not clot all the time. Yes? So a lot of athletes come to Denver, or Thornton is the Olympic training center, I believe, because of the low oxygen atmosphere, encouraging EPO, so that when they go back to sea level, they have naturally higher EPO, and though their red blood cells are naturally higher in a way that's not going to hurt them. The opposite of that is blood doping, when people take EPO at sea level or wherever they are to increase their red blood cell count and increase their oxygen carrying capacity so that they do better athletically. But that's not physiological, is it? So now they're going to be prone to clotting. Yeah. Correct. Yeah, that's why we have our training center for the Olympics, is because we're one of the higher elevation places that you can train for the Olympics. It's safe to do that when you're here. I actually looked into this. A student had that question. If we're all polycythemic here in Denver, are we all going to be more prone to strokes and heart attacks? And I had to look into the primary research, and now I sound smarter when I say we have discovered that we do have slipperier red blood cells than people at sea level do. So we do have that as a compensatory mechanism to keep us from clotting all the time. It takes a little while. Yeah. I don't know. I don't have a tight time frame. All right, hemostasis and blood coagulation. Remember, you've got a pretty complex clotting cascade. I never had you learn the entire clotting cascade, but hopefully you remember that there are clotting factors, that fibrin needs to turn into fibrinogen. We're going to have stages of clotting that are all really, really important, have to happen in order, and then that clot has to be removed in a specific order so that we don't embolize, right? Complex process can go wrong in a lot of ways. Surprise. So we have our hemostasis, we have our initial injury, vasoconstriction, primary hemostasis, we have the deposition of some collagen fibers, we have some platelet adhesion, We have conversion of thrombin into prothrombin, fibrin into mixing it up in my head. Sorry, guys. Again, we have deposition of fibrin, and that's going to help adhere our platelets, our white and red blood cells to aggregate into this thrombus. Now, again, a thrombus being a stationary clot. That clot is going to retract. It's going to help the sides of the epithelium meet each other. That epithelial tissue will heal from below the clot, add a new basement membrane, undergo mitosis, and eventually replace it. And then we have to degrade the clot properly. So here are your stages. And again, I never need you to learn every single factor in order in this cascade. That's not going to help you long term. There are some sadistic A&P professors out there who would make you learn this all in order. I'm not going to do that. I don't think. I went to a patho conference and the pathologists didn't know this, so I'm not going to make you know this. What I do need for you to understand this, here it is, fibrinogen to fibrin, we were just looking at. What I do need you to know from this is that there are, in fact, a number of proteins in a cascade. They're acting like enzymes. They all have to interact with each other. They all have to be there for the final clot to form. That's really the major takeaway here. There's factor, for example, 12, factor 11, factor 9, factor 8. They're not in order by number, so that's part of why I'm not making you learn this. They all are part of this cascade for a proper clot to form. The ultimate thing that's going to happen as a result of those clotting factors is the conversion of fibrinogen into fibrin, which allows for the formation of the clot. A lot of this is coming from the liver. A lot of clotting factors are coming from the liver. The fibrinogen is a plasma protein from the liver. The platelets we know are megakaryocyte fragments. So that's coming from red bone marrow. That's the only exception. So keep that in mind for when we get to digestive and start talking about the liver. Liver is going to be super important. It's going to do everything. And then, of course, we have to break down this clot in a way that does not cause an embolus. So we're going to need plasminogens. We're going to need collagenases. We're going to need to break it down piece by piece and essentially digest it from the inside so that it can clear in the bloodstream without clotting something, without causing ischemia. So we don't want too much clotting. We don't want not enough clotting. Both of those are going to be problems. If somebody is having a problem with clotting, there's going to be several signs and symptoms associated with that. We've already mentioned petechiae, purpura. Here's some ecchymosis here. So signs that there's hemorrhages, very small scale hemorrhages in capillary beds. They're bursting open and they're not healing quickly like they should be. That's what these things are signs of over here. Telangiectasia, hematoma. This is hemarthrosis. So one convenient thing about being human is that we are bilaterally symmetrical. So this knee is a normal knee, and then that is how you can tell that that's definitely an abnormal knee, right? That means there is blood in the joint space. Then this is a synovial joint. There's not supposed to be blood in there. There's supposed to be synovial fluid in there. So we call that hemarthrosis. Okay. Blood is leaking into the synovium where it should not be. Okay, platelet disorders, thrombocytopenia. If we suppress the bone marrow, maybe because of chemotherapy or some other things may have happened, we may have a low platelet count. I believe we've already seen this vocab word elsewhere. Low platelet count, prolonged bleeding time, and all of those signs we've already seen. Thrombocytosis means elevated platelet count. And there is such a thing as transitory thrombocytosis. If you work out like a beast, you are temporarily going to increase your platelet count. Now remember, we have our definition of primary versus secondary diseases. Primary is the thing itself. Secondary is caused by something else, right? Primary is polycythemia vera, or chronic granulocytic leukemia, leading to directly elevated platelet count. Secondary would be a physiological response to something, like a hemorrhage, and now your body's overproducing platelets in response to hemorrhage. Does that make sense? So hemorrhage is its own problem, but now you also have thrombocytosis. Good times. There's also qualitative platelet disorders, such as Bernard-Soulier, von Willebrand, thrombocythemia. It means you have platelets, but they have abnormal action. So part of developing your clotting factors is something called the vitamin K cycle. And I know for a fact that Ashley Watson's going to cover this if she hasn't already. She does a fantastic job with it. So I'm not going to go into detail about the vitamin K cycle. I'm just going to say it's absolutely necessary for the formation of clotting factors. And we've got this drug Coumadin, also known as warfarin, that's going to interfere with it. And that's why warfarin's a blood thinner, because it interrupts your ability to make clotting factors. What's that? Say it loud. Yeah. I'm not a fan of Coumadin personally. I was on it for 3 months. It was terrible. It's the worst drug. We should stop using it. Just because it's old and been around for a long time doesn't mean it's the best. But yeah, if you have problems with vitamin K, even if you're not on warfarin, you could still be developing a coagulation disorder. And this is also, by the way, happening in the liver. So don't forget that liver. Everything's going to come back to the liver. Pretty much everything. DIC, here's a weird one. We covered this in AMP2 because it's just so weird. And I wanted to give you guys space with it. So disseminated intravascular coagulation. Onset of this is poorly understood. There's going to be a trigger event. Maybe it's sepsis. Maybe it's eclampsia associated with pregnancy. We don't know why some people with sepsis will develop DIC and others won't. We don't know why some people with preeclampsia will develop DIC and others won't. As I understand it, it's relatively rare, but it's a pretty big deal. So what's happening with DIC is after this trigger, some kind of widespread endothelium of the cardiovascular system messed up, and the clotting cascade is improperly triggered. That's the parts we do know. There's like a big question mark in the middle of that, but we know the before and after that question mark. There was an intravascular event, and now the clotting cascade is triggered. Yeah, inappropriately triggered. For some reason, we've triggered clotting, and we've triggered clotting everywhere. There's no intravascular injury necessarily, not in any direct, literal way. It's just your body's gone, you know what? I'm just going to clot everything. Clotting all over. So all of the microvasculature becomes clotted. And in the process of clotting, literally everywhere, we use up all of the clotting factors, all of the proteins, all of the platelets. They're used up. So now you have zero ability to make new clots, and now you bleed around the clots you made. And this is when people are bleeding from random orifices. That's a thing. Bleeding from pores. Yeah, what's up? How fast is it get triggered? I'm not entirely sure. I imagine it's pretty quick. So the first step is thrombus formation, thrombosis. The rest of it is bleeding because everything got depleted. That's a simple way to say this chart. So again, poorly understood. It's not me not understanding it. It's science not quite understanding it. I do have 2 EMTs in my AMP2 class, and they said one of them talked about a person they saw with DIC, and that person did survive. It is a survivable event if you get interventions quickly enough. Hopefully, if you're septic, you're already in the hospital and we can get to you. But we're going to be very concerned about anywhere that has microvasculature, like your kidneys, for example. And as I've already been hinting, so much of your clotting cascade comes from your liver. So much of what is happening in your blood is related to things produced by your liver. So if you have a hepatic disease as your primary condition, you're very likely to develop a coagulopathy. So impaired vitamin K, decreased synthesis of fibrinogen, factors 6 and 11. I won't ask you those specific numbers. And so on and so forth. Your liver's in control of everything. Any questions? Okay, so that was clotting. Now we'll go back into some things that happen in larger arteries and veins that are not so much blood, so much as blood vessels. And again, this is back to a teeny tiny bit of review. Do you guys remember blood vessel anatomy? Arteries versus veins. Veins are a little bit more flexible, a little more compressible. They do have a larger lumen compared to the similar sized arteries. They do have valves, whereas arteries do not. Arteries do have a thicker tunica media, which is smooth muscle. And we know there are a lot of connections between blood flow, blood pressure, resistance. The blood volume is a very, very important concept. If you need extra practice for this, I do have one of my AMP2 worksheets posted up under modules. It may not be in this week. I may have to move it around. It is there? Good. So understanding the correlations between these things is actually very significant to you. When we have a low area, surface area, so in your great vessels like your aorta, there's actually very little surface area though. You take out your aorta, you cut it open, you lay it flat, that's its surface area. It's actually not a lot of space. It's actually not a lot of area. Whereas if you were able to extract every single capillary bed and lay them flat, it would be considerably larger in area. And that's going to relate to our blood pressure and blood velocity through these structures. Our blood pressure is going to be higher closest to the heart, closest to the larger blood vessels. And then as it bifurcates and branches out into smaller blood vessels, our blood pressure actually drops considerably. And once it's been through a capillary bed where it's very, very slow, same amount of blood over a very large surface area, slows it down, and it's never going to pick up that pressure on the way back to the heart. There's also this. How are you guys feeling about hydrostatic and osmotic pressure? You remember it. Those gradients. Okay, again, we've got a lot of students transferring in. Did you guys, actually, I think I'm going to pause for a second to ask. We'll just do a quick review on this. It seems like students generally have had this before. Nevertheless, I think it's worth reviewing. So we're going to have the arterial end of a capillary bed and the venous end of a capillary bed. And what we're going to find is that there are generally two competing pressures inside of the blood vessel versus outside of the blood vessel. We mentioned earlier, you're going to have 4 solid weeks of fluids and where they're going, right? That's going to be such a thing in Karen Riley's class. That's what we're here for. So on your arterial end, you have very, very high blood pressure. And that means you're going to have very, very high hydrostatic pressure. It's the literal physical push of water against a barrier, a semi-permeable barrier. So on the arterial end, hydrostatic pressure is going to be fairly high, and a lot of fluid will be pushed out of the blood vessel. The competing pressure that sucks fluid into the blood vessel is known as osmotic pressure. Does anybody remember the plasma protein mostly responsible for exerting osmotic pressure? Albumin. Well done. You deserve a high five for that. So you have a protein known as albumin, and its primary function is to hang out in blood vessels and draw water to it, because where does water go? To stuff. That's what it's going to be for 4 weeks. Where does water go? To stuff. What's the stuff? In this case, it's albumin. Sometimes it's going to be sodium. Sometimes it's going to be glucose. But we're going to say today albumin, right? Okay, so here's your hydrostatic pressure pushing out. Here's your osmotic pressure pulling in like a sponge, drawing water to it. Now on the arterial end, hydrostatic pressure is very high, and osmotic pressure is going to stay stable, right? You have the same amount of albumin before and after. So the net filtration pressure, the net change in water flow is going to be out of the capillary bed on the arterial end. Now on the venous end, you still have the same amount of osmotic pressure. You still have albumin. In a working system, this is normal, right? Working system, you still have albumin. But what's happened to your blood pressure on the venous end? It's decreased considerably. Our pressure, our velocity, our resistance is greatly decreased, and now hydrostatic pressure is very low. So the net movement of water, is it going to be out or in? In. On the venous end, the net movement of water is going to be into the capillary bed. Now, is this a perfect system? Are we sucking back every drop of water that exited on the arterial end? No, it's not a perfect system, which is why we have a lymphatic system to pick up the excess interstitial fluid and return it slowly to the cardiovascular system. So we're going to consider these as compartments moving forward. This is why this is so upfront, and this was why we focused on it so hard in A&P2, is we have fluid in the blood vessels. We have fluid in the space between cells. We have fluid in the cells. We have fluid in the lymphatic system. These are compartments where the fluid can go. And where's fluid always going to go? To stuff. We want the stuff in the right place. Yeah, there are medical conditions in which you lose albumin through the capillary wall. We'll talk about inflammation next week and how we're going to have the capillary walls are basically going to stretch out and be more permeable. You can lose albumin into the interstitium, and that's going to reverse your osmotic gradient to the outside. Did you have a question too? Just ask? Oh, okay. All right, so that was, again, review from A&P2, but I think it's worth it. Now remember, we'll also control blood pressure via vasoconstriction and vasodilation. If you have the same volume of fluid in the same sort of area of a blood vessel, but the lumen is wider, is that high pressure or low pressure? Low pressure. And then if you vasoconstrict and there's less area, high pressure. Good. Good. We're good there. So blood vessels can become obstructed. It can be in the arterial or venous system. The mechanisms tend to be a little bit different, but not necessarily. Really major thing is going to be thrombus formation. We're going to separate the idea of thrombus versus embolus. A thrombus is a stationary clot that persists in an unbroken blood vessel. Really common cause of thrombosis is going to be atherosclerosis. We'll talk about atherosclerosis a little bit this week, but we want to revisit again after inflammation, because inflammation is actually going to be a major contributor to atherosclerosis development. In an unbroken vessel, usually. Now you could say, okay, there's a clot in this broken blood vessel and it's stationary. You would still, in some cases, call that a thrombus if it's not being properly broken down. But for the most part, the ones we're going to see for atherosclerotic plaque, that's going to be an unbroken blood vessel. Yep. An embolus is when all or a piece of that thrombus breaks off and mobilizes. The key here is it's going to hit a smaller blood vessel at some point. If it's too big to pass through a blood vessel, it's going to block, and that's going to cause ischemia. Now let's remember those heart structures. You have the left side of your heart, you have the right side of your heart. The left side of your heart takes blood from where? From where? Right side of the heart from where? The body, and delivers undeoxygenated blood to the lungs. There we go. The left side of the heart takes blood from the lungs and sends it to the body. Okay, so anytime we have a clot, it's going to cause two problems. It's going to cause problems before the clot, where blood gets stuck, so fluid gets stuck. And it's going to cause problems after the clot, where blood is not getting there, ischemia. Two different problems. So when you have an embolus leaving the left ventricle, that's going to the body. One of the first stops off of that aortic arch is going to be that carotid artery. Not the first stop, but one of the first stops is the carotid artery. If it goes to the internal carotid artery, it can give you an ischemic stroke. That's going to be a blood clot in the vasculature supplying the brain. If an embolus leaves the right ventricle, it's going to the lungs. So it's probably going through that pulmonary artery to the smaller blood vessels of the lungs. And that puts you at increased risk for pulmonary embolus. Now you're not sending deoxygenated blood to the lungs, so it can't oxygenate and come back to the left side of your heart. Fat embolus? That would, yeah, a fat embolus is a type of embolus. You can have an air embolus, you can have a blood clot-based embolus, you can have a bacterial exudate-based embolus. All of those. Yep. Yeah, they will all sort of go through this pathway the same way. So we will be revisiting that right side versus left side of the heart, what's before, what's after, where's the blood clot coming from, where's the blood clot going to. And that's going to continue being an effective tool for understanding when we get to heart failure very soon too. So here's that, what we were just talking about, fat emboli, malignant neoplasms. If you have a blood-based neoplasm, that can cause clots. Collections of bacteria or infectious exudate. Air, amniotic fluid can also embolize as well in some cases. Yeah. Vasospasm is also an issue. This is something that actually comes up a lot when we're doing our autopsy visits. If it's a big mystery what happened, sometimes it's not necessarily that there was a physical clot. Sometimes our blood vessels just started going into spasm and blocking off the continuation of blood flow, often for reasons that are poorly understood. Let's see, hormonal changes, food additives, environmental factors may be playing a role, but we don't always know why some people go into vasospasm and have those ischemic events happen as a result of that. A major issue would be if you're having vasospasm on your heart, coronary arteries, going into blood vessel spasm. So let's talk a little bit about atherosclerosis. Again, we will talk about this more in detail with some of the sort of sequence of events that's going to happen in our inflammation lecture. Atherosclerosis is a long-term process. It starts small and it ends big. What we're going to have is usually there's going to be some disrupted endothelium. You're going to start building thrombus. What's really happening is you're depositing lipids into the blood vessel walls in certain areas, very problematically, of course, being the coronary arteries. So let's just say this is in the coronary artery. We start depositing fat there. And again, we'll talk about cholesterol more next week and how some forms of cholesterol just like to dump all of their fat into arteries, which is not where they belong. And then you're going to have infiltration of really well-meaning white blood cells that are going to come along and try to clean that up. But then those white blood cells get stuck, and we're going to look at a really, really great picture of a possum in a bakery next week, and we're really going to enjoy it. So those now are becoming part of the thrombus. The white blood cells that came to clean things up are now stuck. They're part of the thrombus, and it grows. And sometimes that can change the nature of the endothelium and make it sticky and adhesive. And that can grow the size of an additional clot on top of that. So that's going to usually be a multi-decade process. That having been said, I have seen a 27-year-old with 75% occluded coronary arteries on the autopsy table just 2 quarters ago. I wish I was. It was very depressing. Okay, so again, we'll revisit that with inflammation. Any questions about atherosclerotic plaque for now? Again, even when it's a partial blockage, it doesn't need to be a complete blockage for it to start causing problems, mild hypoxia. This is like state that's going to give you angina, chest pain, right? It's not necessarily that you're going to have a heart attack at this phase, but you may have issues delivering enough oxygen past the site of that thrombus. And if you go into vascular spasm in this state, you're in much more danger of having total ischemia. Yeah.
Is this something you can see like you see certain things with like ultrasound? Is this something you would be able to see?
On ultrasound? Would you be able to see obstructed coronary arteries on ultrasound? Coronary arteries are really pretty small. I would have to ask a professional in ultrasound. You can visualize some pretty cool blood vessels with ultrasound. There's a specialty in ultrasound. Yeah, but I don't know what the size limits are on that. Yeah, you can do a CTA. CT with angiocontrast, and that will definitely show any areas of stenosis like this, or sort of thinning and sclerosis. Yeah. So that would be my go-to if I had my choice of diagnostic criteria. I don't know if you could see that. It'd be interesting. Always had to do that. Okay. Yeah. A couple of more. We'll do aneurysms, and I think we'll stop there before we get to valve. No, wait, we're so close to finishing it. Let's see how far we get. We'll do Raynaud's. Raynaud's is another poorly understood thing. Not just me poorly understanding it, science poorly understanding it. Somebody with Raynaud's syndrome is going to have extreme vasoconstriction, producing cessation of flow to fingers and toes. It's really poorly understood. So somebody with Raynaud's syndrome should not be in a cold environment. The cold is going to trigger that vasoconstriction, and just being like in a cold room, let's say 5 degrees colder than we are right now, would have lips turning blue, would have circulation cut off in their fingers and toes and extremities. So it can be a rather serious thing. Let's see. Oddly enough, off-label use for Viagra, since it's a vasodilator, it's actually highly effective for Raynaud's syndrome. Okay. Let's clarify what aneurysms are, because the general public has a poor understanding for what an aneurysm is. An aneurysm means a localized arterial dilation. It's like when you take a balloon and you squeeze just a certain part of it and it bulges out, and that area of the balloon is thinner, right? That's what an aneurysm actually is. So here's a true aneurysm: saccular aneurysm, fusiform aneurysm. I'm not going to have you differentiate between those two things. This area of the blood vessel wall that's bulging out is thinner and more vulnerable to rupture. So the aneurysm itself is not generally killing you. The danger of an aneurysm is it going to burst and cause a hemorrhage? If it's in your brain, it'll cause hemorrhagic stroke, which is why I was phrasing it that way. There's true and false aneurysm. This is also known as a pseudoaneurysm or a dissecting aneurysm. This is what I had in my vertebral arteries. So it's a separation of the tunica intima away from the tunica media. This is why you had to learn the tunics, because there's just a thin layer of connective tissue between them. And if you have problems with your connective tissue, it's plausible that for no particular reason they may peel away from it. In a normal person, an injury may cause them to peel away from each other. And when that happens, blood goes between the layers and creates a nice little clot, which is what I had. They can be. They can be entirely asymptomatic. If it's happening in the brain, which is a very tight area, then an aneurysm could potentially impinge on a part of the brain that would cause neurological symptoms, which again, are they going to get those symptoms checked or not before they find out? And then some of them are more dangerous than others. We talked about Marfan's last week and abdominal dissection and how that's going to cause a drop in blood pressure. They hit the ground, they need immediate cardiothoracic surgery, right? So if it's on the aorta, if it's on a major artery, it's more likely to cause a hemorrhage that's going to kill you very quickly. The term aortic arch aneurysm, abdominal aortic aneurysm, those are all very, very scary terms. Okay, it's time to go on break.